Hello, everyone. Welcome to the Department of Psychiatry and Behavioral Sciences Grand Rounds. My name is Joe Caramelli, and I oversee Grand Rounds for our department. So I will say a couple of things about the Grand Round series before turning it over to Jürgen for the introduction today. I do encourage you at any point during the presentation, if something stands out to you, just to write in a comment or a question in the Q&A or the chat. Either one's fine, and I could keep track of those and go through those at the end. I also had learned, I've mentioned this a few times, I heard that there's some people getting together in conference rooms as groups to view Grand Rounds. Maybe you could come up with a group question and the person, whoever logged in, could type in that question and we could go through that. I want to acknowledge the group of people that work on Grand Rounds each week, and I've actually left someone off. I've left Rosemary off, who's helping today, but including Samhar and Brandon and Charles. There are several sources of funding for the series, including the Ripley Fund, the Garvey Institute for Brain Health Solutions, and the Treatment of Mood Disorders Fund. I'll stop there for now, and I will turn it over to Jürgen to introduce today's speaker.
Well, thank you, Joe. Good afternoon. Hello, welcome to everybody for today's Grand Rounds. We have a really special Grand Round speaker today, and that is Dr. Jackie Hobbs. I'll say a few things about Jackie. Dr. Hobbs is, I think, completing her first year as a professor and as a program director for our psychiatry residency program in our department. And I got to say, she has been a really wonderful addition to our department, to our community, to the University of Washington. We were really fortunate to recruit Jackie here from the University of Florida, where she served as the psychiatry residency program director for more than a decade. So Jackie is not new to education, to educating psychiatrists. She has a lot of experience with that, and we're really fortunate. We here are really fortunate to benefit from all of that expertise. I'll say just a few more things about Jackie. She received her MD and her PhD in microbiology and immunology from Indiana University. She trained as a physician and a psychiatrist, but also as a scientist. And in addition, she's a real national leader in quality improvement and patient safety, doing the work, but also training and faculty development in those areas. She's worked closely with national organizations such as the ACGME, the Accreditation Council for Graduate Medical Education. She's been chairing the American Association of Directors of Psychiatry Residency Programs, or ADPERT, a task force that works on the future of psychiatry residency training. She has a very long list of awards as a scientist, as a teacher, and as an expert in patient safety and quality. And today, we're really fortunate to hear from Jackie on the topic of a quality future for psychiatric residency training. What does the future look like? What are the needs from a population perspective for psychiatrists? And what is it that we can do to help prepare the next generation of psychiatric trainees and leaders for that future? So with that, I hope you can join me for a very warm welcome for our own Jackie Hobbs, and we really look forward to your presentation today.
Great, thanks, Jürgen. Thanks for that very kind introduction. Thanks, Joe, and thanks, Rosemary, for helping make this all work today. Let me go ahead and share my screen. All right, so hopefully everyone is seeing the slides.
Yes.
Thanks, Joe. So yeah, I really wanted to have this opportunity to talk to you about what the future of psychiatric training can and should look like, and with a bit of a quality spin on that, and had a little bit of I thought maybe, since a lot of people have probably been on spring break recently, asking the question, are we there yet? You've probably heard that a few times in the last few weeks. Really, it's important that we think about charting the way forward for psychiatric residency training. And this can be confusing and it can be overwhelming. Thus, sort of the arrows going around in a circle. It can be difficult and time consuming. And we don't always have a crystal ball to tell us where we're going. But we're going to review some of the things that will hopefully help us to best, figure out what the future might hold today. So our learning objectives for today are really to outline some of the various population mental health characteristics and the needs that are going to affect the future of psychiatric practice and also residency training. I'm going to describe some of the quality and safety gaps in psychiatry and again, how that may affect training. And I'm going to discuss guiding considerations for the future of psychiatry residency training. So this slide is actually a slide that was made by Sally DeGolia, who is past president of ADPERT and someone I've worked with a lot on this particular topic. And, I think it's a neat slide that really kind of shows all the different things that are impacting us now, but also will affect training in the future. We all know that the pandemic really wreaked havoc and put a lot of strain and is still having an effect on our mental health services. We also know that we have an aging population, and I'm going to go into the statistics with that. We also have populations such as children who are underserved. There are lots of inequities, both socially and in our healthcare and mental health care systems that are affecting the care we provide and how we train. We have an increasingly diverse population. Again, I'm going to show you some statistics for that. But we've also had a lot of innovation that has happened in our field, and we hope will continue to grow as we go forward. We have a large incarcerated population that also has incredible strains on mental health care. And this picture of a supply chain, maybe not so much about goods per se, but actually about the workforce that we have in mental health care. And again, I'm going to show you some statistics that hopefully will help show you a little bit more about this. So, what does the U.S. Census project for the future in terms of our population? Well, it's going to be an older population. So in the next 10, 20, 30 years plus, we're going to see quite an increase in the number of folks who are over 65. In fact, that group will be larger than the group of children. So it's something we have to definitely keep in mind. The diversity, as I mentioned, of the population will also be far greater. You can see again some of the projections out to 2060, where we see a significant decrease in the non-Hispanic white population, but great increases in many of the other populations. So a lot more racial and ethnic diversity in the population. I mentioned the workforce. As you can see from this map, that dark blue means that there are whole counties that are considered a shortage area. So you can see that a great deal of the country is in that range, and if not, in that sort of middle range. So what does this mean for our subspecialties? And again, as I mentioned, we have certain populations that are really underserved. Our child and adolescent population, again, as you can see, these darker red colors, orange and reds, are where, you know, there may be no child psychiatrists in those areas. So, you know, a huge disparity there. For addiction psychiatry, you see much the same, with a majority of the country really without any addiction psychiatrists. And this is in the wake of having an opioid epidemic as well. And then we have our, again, as I mentioned, we're going to have a much older population, and you can see that we don't have enough geriatric psychiatrists, as again, most of the country you know, does not have any geriatric psychiatrists. So again, what does this mean for the future? Some other things to really be thinking about is probably as psychiatrists, we're going to be treating the most complex and treatment-resistant patients, as many of patients who are maybe having, you know, milder illness will likely be seen in primary care settings or by non-psychiatrists. So this is something we have to keep in mind. If our patients are actually more ill, sicker, then they're going to need innovative treatments. As you can see, just thinking about some of our neuromodulation treatments, you know, those are going to be incredibly important. And so, you know, training needs to also, you know, follow that. So what else do we need to be thinking about? You know, our program mission here at the University of Washington is to improve the health of the public through delivery of behavioral health care to individuals and populations. So again, looking at some of these different population needs and disparities, these are really things that we're going to need to focus on as we go forward. So I'll be, you know, honing in on some of this as we go. So ADPERT, our program director's national professional organization, has really been thinking about this a lot, because in 2025, the ACGME Psychiatry Review Committee will be reviewing and revamping our psychiatry requirements. And so we have to be ready for that, because again, the ACGME wants us to really be thinking forward for at least a couple of decades, because the graduates that we have now are going to be the ones treating those patients during that time. So the then president of ADPERT, Sally DeGolia, a couple years ago, she commissioned this task force, the Curriculum and Assessment Review Task Force, to actually start to think about what we might recommend to the field and to ACGME when they do their deliberations. And you can see we had several members of this task force who came from all over the country. You may recognize a couple of names out of the University of Washington there. And it was a great group that came together to work. We also worked closely with Dr. DeGolia and also John Young, who is now the president of ADPERT. So what this task force started, we sort of laid the foundation for how we're going to think about things going forward. So we came up with 14 guiding considerations, and we really broke them down into 3 groups. So this is the first group that I'm going to show you. It's just a couple of those considerations, but they really were foundational and reinforcing of some of the existing curriculum. And you might look at that first one there, psychotherapy should remain a core element of psychiatric treatment and training, and think, well, duh. A lot of people would, but I think that there was a lot of concern on the committee that, psychotherapy could get lost. And there was a lot of sentiment that it was very important that this remain a core element of training. Not just for actual practice and doing psychotherapy, but actually to inform how we do other things like our medication management. And really learning about our identity as psychiatrists, which I think is really important for trainees. There are a lot of forces out there that are trying to sort of keep psychiatrists from doing psychotherapy, just from payers, for instance. But again, we feel it's very important that trainees have this as part of their identity, that they can choose to practice this if they want. We also just wanted to underscore the value of the biopsychosocial model and appreciating that for treatment modalities. So this next group was really, again, most of these are curricular elements. They are part of the requirements, but we really felt as a group that there needed to be additional emphasis or elaboration or even some curricular change in these areas. I highlighted a couple of these because I think they really sort of go along with some of the themes that I'm going to focus on today, but doesn't mean that they're any more important than the others that aren't highlighted. So there was a strong feeling by this task force that because we will be taking care of more severely ill patients in the future, that it's very important that our trainees be grounded in primary care. And one of the issues with primary care training for our psychiatry residents is that we often send them off to internal medicine or family medicine or neurology, and we just kind of say, go learn those things and then come back to us. And I think that there was a strong feeling that there needed to be more specific and updated primary care goals. So that was something that we definitely wanted to highlight, again, in this context of taking care of folks who are going to have severe mental illness, but a lot of co-occurring medical issues. We want residents to be able to be equipped to practice in lots of different settings. And, not every program can train in every setting, but having variety as much as possible, we think is very important, whether it's rural training, community training, urban training, prisons, working in that sort of setting is very important. We also felt, again, as mentioned, that there should be specific requirements for the knowledge and skills in neuroscience-informed interventional neuromodulation treatments. Again, very important to understand these innovative treatments going forward. I will spend quite a bit more time on the quality improvement and patient safety competencies, so I will move forward from that one in just a moment. We also want our residents to continue to be lifelong learners, being able to keep abreast of all the different modalities of treatment and assessment of patients. And for instance, being very aware of things like AI, machine learning, all those sorts of things that are going to affect how we deliver care in the future. So this third group really was items that was felt by the task force that really needed major changes, that they would be major changes in psychiatrist role, or there needed to be curricular changes or changes to assessment. This first one is no stranger to the University of Washington, that residents should be able to lead interprofessional and collaborative care teams. And I think that it's, this is growing across the country, but, there are still programs out there. The task force, did survey programs and program directors. There's still gaps in this area. So this is definitely something. Again, we will be taking care of probably the most seriously mentally ill. We'll probably be doing a lot of things in conjunction with primary care providers and other providers. So, yeah, super important for the future of residency education. We also felt that residents should attain basic specified competencies in subspecialty care. And a lot of this is driven by the fact that we don't have enough child psychiatrists or addiction psychiatrists, that really, all general psychiatrists should feel a lot more comfortable taking care of these populations, and at least being able to do some very basic things and being able to really define what that is for our future grads. Going along with that, just being able to take care of patients in a very developmentally informed approach across the lifespan. And again, being able to, really diagnose and take care of, very common conditions across the lifespan. These next ones, I think, we could spend a long time talking about, but very, very important. Delivering care from a place of structural and cultural humility, and working to provide professional and ethical care, and advocating for an end to health disparities, mental health disparities, and providing patient-centered and evidence-based trauma-informed care. Task force felt very important. And then I will spend more time on determining resident competency and using reliable and validated assessment tools, especially with an emphasis on direct observation going forward. So those are our 14 guiding considerations. As I mentioned, I'm going to focus a bit on one of them in particular, which is that residents should acquire quality improvement and patient safety competencies through meaningful work in their clinical learning environments. So I'll start just by highlighting a study that we did a few years ago that really looked at some associations with board scores and programs having an emphasis on patient safety and interprofessional teamwork. I did this alongside some of my surgical colleagues and GME colleagues, and we really looked across lots of different specialties and subspecialties. This was not just surgery or psychiatry. And what we found was that residency programs emphasizing patient safety and effective interpersonal teamwork had above average first-time national board pass rates. And really what we saw was that when the culture reinforced patient safety, that's when you saw this improvement. And also we even saw things like having a culture that really focuses on transitions of care, handoff, also very much led to this association with higher pass rates. I wanted to show some data that I felt would sort of really bring home the point that that we're not there yet when it comes to quality improvement, patient safety. And this data, a lot of it comes from the VA system, which is great in the sense that the VA probably one of the closest things we have here in our country to sort of like a national registry. So it's pretty powerful in the sense that you have a lot of, you know, high numbers to look at. And so a couple of these studies came out, and this was the data did come pre-pandemic, but I would venture to say that things haven't changed too much, especially for the better since the pandemic. But what they did is they looked at patient safety on inpatient psychiatric units at the VA nationally. And what they found is that 1 in 5 patients actually has some sort of medical error or adverse event that occurs. And the top ones were medication errors. That was the highest one. Adverse drug events, falls, and assaults. And the majority of these were found to be preventable errors. And the other thing to know is that most of these, you know, greater than 90%, led to little or no harm. And so you say, well, so what's the big deal? Well, you know, it only takes one, right? One very catastrophic error that can really be a terrible event for the patient, for their families, and for the care providers that are involved. There was also a follow-up study where they compared the VA data with community-based general hospitals that had inpatient psychiatric units. And they actually found that those community-based hospitals had they're twice as likely to have their patients experience an adverse event or medical error. And this is not to point any fingers and say, you know, this place is the ultimate thing we have to take away is that we still have a lot of work to do when it comes to patient safety in psychiatry. And it needs to be an important thing that we talk about, that there's still a lot of Swiss cheese holes that may line up out there. And this is really important for training. This is one other study, again, came out of the VA system. And you can, what they did was they looked at their RCAs. They had about 87 RCAs over a 2-year period. And they had almost 10,000 patient safety reports in that 2-year period that they looked at. And you can see the first graph here is really from the RCAs. And most RCAs that are done, typically I would say in a VA system, are going to be pretty negative, bad outcomes. So I think you see a lot of these are suicide attempts, there are elopements, you know, hazardous things being brought onto the unit, assaults, falls, but even deaths. And you'll see that some of these events led to either major or even very severe injury, and again, deaths on our inpatient units. For the when they broke down the suicide attempts, you can see the different ways that has occurred on the units, and again, sort of the different levels of injury that can occur. And this is the patient safety reports, and the majority of those were for falls, but also medication events are really high up there. And I think if you hear that trend from the other studies, you'll again see that medication events happen quite often. So it can be anything from just missed doses, wrong medication, all of those sorts of things. So I wanted to let you know what the ACGME is really thinking about quality improvement and patient safety curriculum for residents. There is a major focus by the ACGME. I've been involved working with them to really train more program directors, associate program directors, and interested faculty to learn more about how to teach quality improvement and patient safety in residency training. And one of the things, so what I'm showing here, if you look, many of you may be familiar with the GME milestones, how our residents typically come in at around a level 1 in their knowledge and skills surrounding QI and patient safety. Then over time, during like the first, second, third years, they attain higher levels of that knowledge and skills, and we hope that at some point, by the time they graduate, they will get to level 4. The ACGME actually would like to see this curve really move up and to the left, so that we actually get residents coming in and getting very quickly from basic to advanced participation. And then, again, ultimately getting to level 4 or higher with some basic leadership skills before they graduate. So the milestones, really what the ACGME is pushing for the milestones, is to really get residents as quickly as possible to level 3. And you can see for this, participates in analysis of patient safety events, so RCAs, participating in disclosure of patient safety events to patients and families, and participating in local quality improvement initiatives. Really, they would like to see these things happening in the first, if not the second year of psychiatry residency training. And they are looking at all specialties. They really want to get all specialties up to this level very quickly. But just for us, thinking about it in our time frame, we really would like to see this much earlier. Than what many programs tend to do is wait till the 3rd year, the outpatient year, when it's a little easier to sort of, to adapt your schedule to allow these this sort of work. But by then, it's starting to get a little late, and residents don't really have enough time to really gain the knowledge and skills they need and practice implementing it over and over before they graduate. Same for handoffs, being able to perform safe and effective transitions of care, and in complex clinical situations, not just day-to-day routine. So, I think that, the major focus is really early training, and we need to get there. We're not there yet, and so I would ask that everyone think very carefully about how they design their curricula around quality improvement and patient safety. I'll switch gears just a little bit to talk about another potential aspect of the future residency training. There's been a lot of calls to sort of standardize training across the country, or at least have part of the training be standardized, and by having a national didactic curriculum available to residency training programs. We have the largest psychiatry residency training program here at the University of Washington, but there are lots of programs that are new, very small, and maybe very under-resourced. So it's really critical that everyone we graduate from psychiatry residencies across the country should have a certain level of training and including didactic curriculum. So again, trying to standardize things. Standardization helps to help improve quality. When we put out this call, that letter to the editor of academic psychiatry, we just kind of threw out an example. What would this maybe look like? It's not a small feat to do this, and I think it's really important that we think about like how much time and effort, faculty time and effort, really goes into developing a full 4-year curriculum. What we proposed is maybe having like half of that curriculum, maybe 2 hours per week per level. Remember, we have to have level specific training. And still it's a lot of hours of curriculum to put together, but I'll show you some examples of other specialties who are doing similar things. It'd be great if this was sort of an online, accessible, asynchronous type of resource. We can't all always be together at the same time, and there's just a lot of people to try to train. So allowing the programs to utilize this in their own local site is very important. Case-based learning also be a really important factor for this. It's something that I think really engages residents and anyone, faculty as well, in learning. And again, there should be flexibility in how this is used. And I think that some programs might feel, especially if they have a great curriculum, it's a larger, well-resourced program, they might say, why would I want this? It's not that they would have to use this. They, could opt out of it if they met, the standard. But they could have it as a resource, or they can develop on top of this curriculum any innovation, any specialty work that they do at their local site. Again, here are these examples of some national curricula that are out there. The American College of Academic Addiction Medicine has a weekly live 2-hour didactic that they do. This training is usually a year in length, so it's a little different than a 4-year curriculum. but it is there available to members. And it's mapped to ACGME core competencies and their board exam blueprint. There's also Foundations of Emergency Medicine, which has a series of courses that's openly shared with their residency training programs. It has a flipped classroom style, so they have these curated asynchronous resources, and then the program would have, classroom time and have case-based type and small group type work. So, our specialty has, we have the PRIDE exam, we have our ABPN exam blueprint. We have all the necessary, we know what the content really can and should be. So, I think it's very possible to do this sort of thing. It's just going to take certain things to help with that. So the barriers obviously are the cost and who actually absorbs that cost. And this is cost for administration of the program, keeping everything online, IT support, storage, those sorts of things. Keeping it sustainable, keeping having the maintenance on it, updating it as we have new findings in the field, takes a lot of time and effort again. So you can think about that and what you think about a national sort of curriculum. And I'll move then to the last part where we talk about how are we going to really assess residents and whether they're ready for graduation and are they ready for that future state to take care of patients. And so the task force really wanted an emphasis on how residency competency would be determined, that it should be through reliable and trustworthy assessments, and that it would involve a lot of direct observation. So in terms of assessment, I think a lot of program directors and faculty sort of cringe. It's kind of like, when people start talking about math or something, like people don't want to think about it. But it is crucial to really knowing whether your curriculum and what you're training residents to do, that's actually working. And, if we go back to Miller's pyramid, there are various levels of assessment. We all know the good old multiple choice questions that most people don't care too much for, but it's still a relevant part of assessment, and seeing what residents know. And then as we move up the pyramid, we get into more of getting into action where the resident can actually show that they know things, that they can take that knowledge and actually use it clinically. So we may look at, again, we want to have observation of residents. We might do direct observation, seeing them perform certain things. We get multi-source feedback through the 360 evals from staff, and we might do a performance in practice. And so again, that might mean that we do a medical record audit. Is what we're teaching the resident about how to care for patients who have schizophrenia or major depression. Are they following the guidelines, the practice guidelines for that? Are they following the latest in our medical literature? So this brings me to the concept of competency-based medical education, which has been around for decades. It's not new, but I think we're sort of in this period of rediscovery of it in psychiatry. I think, again, lots of pressures, from the pandemic and society have really sort of brought us back to this point of trying to demonstrate that residents have competence for unsupervised practice. And it really involves, again, a lot of, being able to observe residents to do certain things. Can they evaluate patients in various settings or, various diagnoses? Then can they do a discharge summary? Can they do an admission? Those sorts of things, and really being able to document that. But also knowing that that doesn't just happen overnight. It doesn't happen once. You have to sort of do these things over and over again in different settings. And there has to be constant feedback to the resident to really be able to keep learning and keep improving. This also brings up the concept of whether residency should always be 4 years for psychiatry. It's obviously different for other specialties. And really the concept of time variable training keeps coming up. For some residents, they may be able to finish sooner if they can meet their competencies. Others might might need a little longer, and that's okay. It's just like the milestones. Everyone sort of gets there at different points. To be able to do this, you really do need those trustworthy assessments. There's a lot of concern about CBME because of a lack of these trustworthy assessments and possible inequities that may be introduced. We can all think, like of a resident who we thought was just stellar, and sometimes we can sort of get we can sort of forget that maybe they don't know certain things or don't have certain skills because we've had these great interactions with residents. So we have to take sort of that human bias out of there. This really requires a lot of faculty time and development so that they understand how to use the tools that we have, these trustworthy tools, that they can do the observations, and that they can give that constant feedback to the residents. There's also, there's a paper out recently talking about promotion in place. And I think this is kind of an interesting way of, if you keep residency at the same time frame, because some of this really is, we have this structure in place that is very hard to change because of funding sources, just the way hospitals are set up and run. So it's very hard to just say, okay, well, this person may be out in this short amount of time. You never know what your workforce is really going to look like. So the concept of promotion in place is that you keep time-based training, but then towards the end of training, the resident could be promoted to being able to serve as an attending during the last period of training. And this would be considered a sheltered independence. You could also think of this as promoting to fellowship early. And then, even then the fellow promoting to attending early. So it's a very interesting concept. I think it's something that folks are thinking about in terms of also helping with recruitment and retention of faculty as well. So I adapted this example from the paper just to give you an idea of what, this, promotion in place might look like, this sheltered independence in psychiatry. So maybe at the last 6-month mark, could be a year. We don't know what that might look like, but let's say the last 6 months, they might continue working in their continuity clinic, but they would be the attending of record. They wouldn't have routine supervision, but they could consult if needed because we're still there. And I kind of chuckled about this one because this is the way I actually was trained in the early 2000s, because I was in a system that didn't really require such billing oversight. They might complete their scheduled CL rotation, and that way another resident doesn't have to cover that, and they would serve as the attending. And then the attending who was actually, originally on, could do something else during that time. They could teach, they could be working on a scholarly project, whatever it might be. Then the resident might complete their scheduled perinatal and community elective, and they would act as a resident when they're doing those, because, they want to get that extra training. They're not really at the attending level for that. And then they might, complete a scheduled inpatient rotation. Again, that way another resident doesn't have to do it, and they act as the attending of record. The attending who originally there gets relieved and can do, again, more teaching. So this is just a model. I'll just sum up, by saying that, we have a lot of things to think about. When I originally got on this task force, it was like, wow, so just revamp everything. So it's not easy. So we really had this first step in looking at sort of those foundational things that we wanted to keep a focus on. I'll say that we greater focus on primary care and the subspecialties in psychiatry. And also so we can care for a very diverse population. A big focus on QI patient safety training, and having potentially a national standardized didactic curriculum, and really thinking about this competency-based medical education. And that is the next task force that has been commissioned by John Young for ADPERT. And I will get to participate in that, and really excited about that. So more to come. And I'll leave you with some references. Thank you so much for your attention, and I will take any questions.
Dr. Hobbs, thank you for this presentation, going through the need, what training's trying to accomplish, the ideas about quality, associations with it, and what's happening here and what might be coming in the future regarding training. It's very, very interesting to think through this. I think a lot of us think back to our own training, maybe at times without realizing, well, it keeps changing. So thank you. A couple of questions did come in, and I want to ask you about this. This maybe is about the first part of your presentation. This question came up regarding caring for people with the greatest severity psychiatric disorders, while acknowledging that nationally, most psychiatrists aren't accepting insurance or Medicare or Medicaid, which might be at odds with that aim. And the question is, how can psychiatry residency training impact that?
Yeah, I think that's a great question. And I don't know if I have all the answers to that. I think that, that also gets at a very important part. And, when I talked about some of the patient-centered care, and, I think it comes back to advocacy too, right? And it's something we have to really train our residents to understand that and know how to advocate, whether it's at the at their local systems level or at the state, regional, or national level, and really getting involved with some of their national organizations like the APA, for instance, to be able to help advocate so that, you know, payers will pay and that you know, there will be parity, et cetera. So I think that's one way to potentially get at this. But great question.
Thank you. A question regarding evaluation. What has been the impact of discontinuing the psychiatry oral board exam? So, this has maybe been what, for content, has it been 10 years that that's happened? I don't know.
That probably, yeah, it's probably getting around that point. Yeah, it's very interesting. You know, I think that we've asked ourselves that question many times. And I know the senior residents here chuckle about me because I was talking to them about how I actually liked the oral boards. It was scary as can be, but I actually thought it was great to have someone else like actually like say, okay, you're safe to practice and that sort of thing. Yeah, I think that, but it is good in the sense that, you know, we do the clinical skills evaluations, our faculty do that. And, you know, I really, you know, there are only 3 that are required for the board. ACGME requires that we do something like this every year, so 4 maybe. But I'm always like, no, let's do more. Like, you should do more of these. Like, try to do one on every psychiatry rotation, because getting back to CBME, you really want to be able to see a resident in action. And sometimes I think we get these snapshots of residents. We see them for just a few minutes, maybe talking with a patient, interacting with staff, whatever it might be. And it's just that it's a snapshot, and it doesn't let us see them, you know, fully doing what, you know, a full workup. And so I think that, you know, I think there are good things about it. I think we could do it better.
Thank you. A question, yeah. So I'm wondering, maybe I could broaden this question out. A question came in regarding working with psychiatric NPs or APPs broadly. If there's overlapping training, I mean, people are working together clinically, either in hospital settings or in the clinic. The question specifically was regarding sort of safety concerns, but I wonder if there's maybe a broader area of comment regarding those interdisciplinary teams.
Yeah, well, you know, as one of the guiding considerations was, you know, that we really, as psychiatrists, need to be able to lead these interdisciplinary, interprofessional teams and collaborative care teams. And so, you know, I think it is important that we find a way for us to sort of train together. I think that we've been in this place of, you know, nationally, you know, being like so siloed. And there's always this concern about, you know, who's in charge, you know, is somehow this going to take away, you know, like from the psychiatrist. And I think what ACGME has really been pushing us to think about is, you know, what is our role, you know, as a psychiatrist? I think we have to really ask ourselves that question. What is it that we are best trained or should be best trained to do in psychiatry and in medicine in general?
Thank you. We have about 30 seconds. With very little time, a complicated question. I hesitate to bring it up, but it's interesting. Maybe you have a brief response about if concerns have been raised about promotion in place, maybe leading to potentially people feeling upset, dynamics in the residency class, I know what people being promoted too quickly, how can it be undone? Yeah, concerns about that, have those been raised, or and what are the thoughts?
They're totally being raised, and it's part of the new task force, and at least a couple of members on that task force are there specifically because of their expertise in that area. And so I think there's way more to come. It's a huge concern, and so you know, I think we have to be very careful with it.
Okay. Well, more to come in that area, and clearly with the future of psychiatry training as well. Thank you, Dr. Hobbs, for presenting today during Grand Rounds. And I think we're just past 1 o'clock here, so we'll need to end. But again, thank you.
Yeah, thank you.
Okay. Bye.